All right, we are now
Thank you so
going
much,
to
Dr.
gather, thank you so much, gather for our Diversity Champions in Healthcare panel discussion. So we'd like to have those that are participants to join the screen at this time.
Dr. Allen, I'm adding them to the screen.
Thank you. All right, let's see who we have on.
Hey, Vicky, have not seen you in ages.
I know, Dr. Perez. How are you?
I am so good. I'm so good to see you, and you too.
You know, earlier, Dr. Okoye mentioned that I met her when she was a resident. I met you when I was a resident.
I know.
And you have been the kindest, most supportive, most brilliant mentor, friend, and role model that anyone could ask for. So it's great to see you.
Thank you.
Excellent. So on our panel, I have on my left, Daniel Debrelli. He is a fourth year graduating medical student. We have Dr. Chris Harris, who is a graduating family medicine chief resident. We have Dr. Robert Salinas, our assistant dean for diversity here at the College of Medicine. And of course, we have Dr. Ted Rosen with us. We have all of our participants, Dr. Perez, Dr. Heath, Dr. Barbosa, Dr. Okoye. Have I missed anyone? Let's make sure that all of our panelists are on. I don't know if it's possible from our CPD office to hide the other people on the screen and just have the participants in squares.
I am working on it, so
Okay.
if y'all would like to go ahead,
We'll just do that. And so we have really intertwined today with a lot of discussion surrounding healthcare disparities, bias in our academic settings and patient care areas. And we need to find a solution. We've talked a lot about the problem, but how do we get to a solution? What needs to happen? And I know that our American Academy of Dermatology has started for the past few years, Diversity Champions in Dermatology, and it is actually a conference that brings us all together and discuss some of the things that we're doing at our own universities to tackle this issue. And so that our voices are heard and people can really see us. And so at this time, I'd like in just a few words from our panel, in your own view, what does a diversity champion mean to you? And what does that look like in our academic healthcare setting? So anyone, take the floor. Daniel, I'll let you go as our medical student.
Thank you, Dr. Allen. It is a privilege to be here. And from my perspective, the key element, the key paradigm that I look at this is as a student, correct? And so with that, a diversity champion are those faculty and those administrators that really go out of their way to listen to the students' concerns and empower them to help affect change, whether that be through curriculum, whether that be just listening to, hey, here's a challenge that I'm facing that I didn't expect to face. And so with that, that would be, from my perspective as a student, what a key diversity champion is.
Thank you. Dr. Salinas?
Thank you, Pam. And once again, thank you for the invitation to be part of this wonderful educational activity and our wonderful panel from throughout the U.S. And of course, our student Daniel and our resident Chris. You know, it's a very interesting question, and we could, you're right, spend the whole day discussing what a diversity champion means and what the responsibilities are. But I think from my perspective, it's about educating myself and then helping educate others that we're all different. We all contribute in different ways, and the collectivism is what makes us better and stronger.
Excellent, excellent. Dr. Perez.
Well, I think that a diversity champion has to do what I told you that I did this morning is, we have to learn how to canalize our positive thoughts to educate the next generation and our colleagues around to deliver the best care that we can to all included. And so therefore, every patient has to be an ally, not important of what the ethnicity, the socioeconomic, the religion is. We have to be the advocates of every patient.
Excellent. Dr. Barbosa.
It's very interesting because I think to be a diversity champion is to constantly be trying to move the needle forward on diversity, equity, and inclusion. And sometimes that's in small ways. It's in, educating the resident who's maybe uncomfortable about Spanish-speaking patients, or maybe it's educating a patient about why a joke that they think is funny isn't really that funny. Sometimes people think they can tell you a joke about a different group. It's still not okay. But there are also opportunities to have larger structural impact. So for instance, when I got to U of C, I realized we've got an amazing diverse section, but we don't have a plan. So I worked with other volunteers to join the, I just called it a committee. Okay, we don't have a diversity committee. And we put together a plan for the section so that we could be, really thoughtful about how are we gonna make sure our residents spend their 3 years learning more, both about disease and about the social context in which our patients exist. Who are the lecturers that we can bring to bear? What are the topics that need to be here? And then you look around and say, now what else needs to happen at my institution? So I think there are little things we can do and there are big things we can do. And the one other point I have to make is that this is not only the job of those of us who've been living this. I love what Dr. Perez said earlier, for many of us, the weight of these, Dr. Heath said, now we have a name for it. The weight of these microaggressions on our daily lives is exhausting. And this last year has been ridiculous. Every day, there's more news that's concerning. And we're tired, right? We keep going, but we're tired and we need allies to help with this fight.
That's right, the minority tax.
Right.
All right, Dr. Okoye.
Dr. Allen, I think dermatology is still, of course, very new to this diversity discussion. And we can learn a lot from some of our colleagues in internal medicine who I believe started some of these conversations a little bit earlier. And I think at this point, we have two types of diversity champions, in my opinion. We have people who've been assigned to be a diversity champion, and then we have people who belong to an ethnic minority group, and they're the only one at their institution or in their division or wherever, and they were the obvious choice. And so I think the problem with either of those strategies is, I think diversity work is a skill set. You don't automatically pick it up because you're a minority, and you certainly don't pick it up if you're not a minority. So I think we have to do a better job of educating our diversity champions to do that work. It takes some grace. It takes the ability to really proctor very difficult conversations. And those things can be taught. So I think that's my view as a diversity champion, as someone who is educated in this subspecialty. And I think we need to invest some more in that.
Excellent. Chris Harris, let's hear from you very quickly.
All right, well, thanks again for having me here. We often talk about diversity and champions of diversity as it relates to patients, and it's very important. Things like knowing that African Americans are undertreated for their pain. So you can't change it if you're not aware of it. So as far as providing care, I think a champion is one who seeks first to understand than to be understood. But also from the teacher to learner perspective or colleague to colleague perspective, I think it's a little bit deeper in a sense of recognizing the microaggressions without the minority individual saying that there is a microaggression, understanding the perception that some people have about different cultures, how different cultures interact, how different people talk. It may not mean anything within that culture, or it's just how it is, but other people interpret it as something negative. And so being aware of those things and then those people speaking out to correct those issues are a couple of the things that I feel like diversity champions can do.
Excellent. Dr. Rosen.
So I'm going to just briefly talk specifically about dermatology. It kind of pains me that we're the second worst specialty in terms of diversity. So what does that mean? So we all have things we have to do. We're taking care of patients. If you have families, you're taking care of families, you're teaching. So there's only so many hours of the day. And I think you can be a diversity champion by picking one activity and doing it consistently that fosters diversity in dermatology in specifics. So what I like to think about is, well, if we want a more diverse workforce, we're going to have more diverse. We need to have more diversity in our residency. We need to have more diversity in our residency. We need to fire up medical students of underrepresented in medicine groups to pick dermatology as their specialty. And so what I do, I've taken on myself. We have a dermatology elective, right? Students sign up about every month, and we usually have a half dozen or so, and they get put in different institutions. And I look and see who are our medical students. And when I see individuals, most of the people who sign up for their derm electives at least are considering dermatology. So when I see individuals who are taking our derm electives, who are part of the underrepresented groups, I approach them and I say, are you interested in derm? Let me help you get into dermatology. That's not a big issue. It's one student at a time. But over the course of years, it makes a big difference. And I help them with projects, and I help them with their applications, and I help them rehearse their interviews. It's actionable because it's on a scale that I, as an individual, feel like I can do. And it's been uniformly successful because that's where we've got to start. I think we even need to start earlier than that. Like we have a high school for the health professions here in Houston. I like to go give lectures there as a volunteer. And of course, I'm going to talk about skin and dermatology. That's how you change the workforce, person by person by person.
I think that's a very important part with regards to how do we change the trajectory of where we're at. This is an inflection point for all of us with this pandemic. We need a Marshall Plan. We need to do something more intentional, strategic, and impactful. And I agree, we have to set up these pathways much earlier to increase the pool of qualified applicants to medical school, to then get them into residency, then get them into dermatology, and maybe even a faculty position. I think Dr. Okoye was asking, the other specialty is orthopedic surgery, I believe, that is not very diverse. But what we've learned in family medicine and in internal medicine is that when you don't have enough faculty members doing this kind of work, there is a risk of burnout. There's, I think Pam mentioned the minority tax, the gratuity tax, the stereotype threat, the breakaway guilt. And these are the things we see in undergraduates that continue in medical school, perhaps, and even during faculty. So we really need to expand the pool of applicants and start much earlier, just like Dr. Rosen is suggesting.
Dr. Heath?
I think it's incredibly important as diversity champions that not only are we recognized, that we do receive some type of academic credit, something, because it does take a lot of time. So that's just one thing I wanted to throw out there. And the other thing is that I think that our overall purpose is to just be a reminder, just to have a seat at the table and be a reminder when someone says, oh, this person's application, they have this on there. Just to kind of bring it up to say, hey, do you know how hard you have to actually push if you grew up like this without any resources to also have your application end up on this desk to be considered as an applicant for dermatology and to actually assign some credit for that. So just to be in the room at the table, to just do these subtle reminders, to just because people always go to these conferences, but it's in the moment when you actually have to act on what you have learned that people often fall back into what they normally do. But diversity champions, we're responsible for remembering, reminding people of the new movements that we're trying to instill.
Exactly. And so what do we need to do? I've heard about pathway programs, recruitment, even into our own specialty, but abroad as well in other specialties. How do we really incorporate diversity in health professions education, medical school? Let's talk about that, and in other health professions as well. But how do we incorporate diversity? What's it going to take in their education?
I think also just including just the health disparities within the curriculum. So not something just separate, but say, oh, we're talking about hypertension in this block, but then also include, food deserts and why people have to go to high calorie foods because they don't have a grocery store. So just weave that in right with the basic science to really plant that seed that, wow, it's way more than just how the heart works, what goes in and out. There are these other factors that can determine what my patient ends up, presenting with when I finish.
Exactly. Dr. Perez, you were saying something?
Yeah, I also consider it, if you look at the diversity or lack thereof of diversity in our specialty, it has to start by, if you want to show diversity and teach diversity, you have to show diversity. So I have taken up on myself the mission that I am in the selection committee for the residents, and I will make sure that the URMs are going to be, at least the ones that have the same qualifications as everybody else, are going to be in the right positions to get matched in dermatology. Because if we do not diversify our dermatology population, remember that our patients feel more comfortable with the doctor that looks like them, that knows what they feel. Right. So we have to increase the diversity in our residency programs.
If I can jump on and also kind of look back to what Dr. Rosen was saying, you're right. I mean, the only way that we can have more dermatologists is to have more dermatology residents first. And it is so incredibly competitive. I mean, a lot of us sit on these committees to select the residents, and it's incredible. We have to get our hands on these med students in their first year. We have to, help them understand what it is that programs are looking for. Help them get plugged into research. For a lot of these students, it'll be their first opportunity, to do, medical research, and we've got to mentor them through that and really help them have a plan so that by the time they're applying, they've got a CV that helps them be competitive. Because a lot of times it's not about whether or not they're capable. It's about whether they've had, 15 publications and presentations, and were they able to afford to take a year off to do some of that extra work, which not everyone can do. So we've got to, it's very hard for someone to come in the middle of their third year and decide that they want to apply in derm, right? It's a little late unless they're willing to take some time off in many cases. So we've got to catch them early and mentor them through med school.
And I think in addition to, filling the pipeline at the beginning, we always talk about the leakiness of that pipeline. And one of the places I think we need to shore up the pipeline is actually at the end. So we have underrepresented minority faculty in academia who are floundering and leaving academia. And our presence, our very visibility increases diversity, because then students and residents see us and they say, okay, I can do that too, or I may get mentorship from this person, or maybe this person is studying skin of color and that's something I'm interested in. So I think it's important for us to think about our faculty, junior faculty in particular, and support them and mentor them, give them protected time and or money to do some of the diversity work so it doesn't feel like a tax. And to invite them to give lectures, invite them to collaborative research, mentor them to get grants, right? I think we need to work on that attrition that's happening in academia.
One of the things that we have to understand when it comes to whether the healthcare system, whether it be providing care or the education aspect, is that every system is perfectly designed to get the results that it gets. And so we can talk about it, we can have diversity champions, but if we don't change the system of getting into medical school, getting into these residencies, get rid of the archaic and outdated mindsets of test scores and these things that, as a Black man, we look at these standardized tests and, well, they were created by white men that only allow white men to pass. And so not only do I as a Black man have to work that much harder just to get at the baseline, right? I now have to work even harder to get competitive. And if we look at the ethnic scaling of scores and understanding that impact and changing how we admit patients or admit students into medical school, into PA school, or whatever it is, then and only then will we really see the diversity in education take the necessary jump that it needs to take.
Excellent. How important do you all feel that being on the admissions board and participating at that level to improve the pathway and potential admissions of people of color students, where they may have been looked over, where you need to be an advocate for that person that is a diamond in the rough. I sit on one of the interview subcommittees for the School of Medicine admissions, and I think it's been an awesome opportunity to advocate for those that may not have had a voice, but you see something in them and other areas that would make a difference and change our system as well. So I just want to know if any of you have participated on those admissions or interview boards for medical school.
Yeah, Pam, I think that's a really good point, but it's at every level. So
Yes,
it's
yes.
not only admission to medical school, it's the committee that's looking at residency choice.
Mm-hmm.
And I think that the most important thing of all, and I would agree with Chris's comment, is you look at the person and you look at what have they done? Where did they come from? What did they have to overcome to get where they are? And what do they bring to the table? It can be leadership. It can be a special skill, like they play an instrument. It can be, what have they done in community service? Forget the scores. That's so not, first of all, it never predicted a good resident, ever. Because we had great scores that were horrible residents, and not so good scores that were wonderful residents, and now are superb clinicians. So empathy, do they have empathy? And when they come, well, now you don't come, you do it by the screen, but when you interview people, you want to try and understand what makes them tick and what are they going to do. You want to be a dermatologist, right? You want to be in medical school. I was on the admissions committee for the medical school too for a number of years. You want, why? What are you going to do with the privilege you get with people entrusting you with their health care? What are you going to do? How are you going to give back to society? That's the kind of question you ask. And those are the kind of things you look, and you can only do that if you're in a position at admissions of medical school, residency selection committees, and so forth. And so it's key to have people who are interested in diversity at those key junctures.
Excellent. We have a question in the chat. Do we know whether the comparative lack of diversity in dermatology persists when controlling for U.S. medical graduates? My expectation was that the reason we and orthopedics are so non-diverse is because we accept so few international medical graduates. Would anybody like to take that question?
Well, I can't speak for obviously dermatology or orthopedics per se, but I think we also have to understand when we look at the term international medical graduates and then also what the AAMC is now classifying as underrepresented minorities are a little bit different. And so we have to you have to factor that in as well to looking at that overall number when it comes to IMGs. And from what I see, majority of IMGs are usually going into family medicine or internal medicine.
That's right.
I was just going to mention, and correct me if my memory fails, but I think one of the things that was really powerful about Dr. Pandya's study that we all like to quote so much is that in that study where he showed that derm was second least diverse field, those numbers actually included, it wasn't just underrepresented in medicine groups, he actually included Asian Americans in that group as well. So even including people of color who are not underrepresented, we were still at the bottom. And I think that's really powerful. And the other thing I want to mention is that he published what in my mind is a equally powerful study a few years later, where he showed what the racial and ethnic breakdown of academic faculty are. And not only are we the ones charged with making sure that our residents are prepared to take care of a broad group of patients, but we are the ones on the admissions committee, and I'm going to be chairing one of our admissions committee next year. But it's hugging the zero line in absolute numbers and percentages when you look at underrepresented in medicine, UIM, men and women in academics. It's pitiful, near zero. I mean, we, mostly have each other on a text string, it's like that. Or actually it's an Instagram group, but whatever. And so we really have to look at not only getting people to residency, supporting them through residency, but we also have to somehow make academics appealing. I left private practice to come back to academics, partly so that I could do this. We have to keep people in academics.
That's exactly the reason that I came back to academics.
Excellent.
Dr. Allen, to your
Yes.
earlier question regarding having underrepresented or having folks like us on the admissions committee, not only is it important to advocate for those students, but it's also helpful from the student side to see someone that looks like you, sounds like you, in order to want to go to that particular institution. And so I think there's a double-sided benefit to having that representation on those committees.
Excellent.
And
And
may I add, Dr.
yes,
Allen?
go right
So
ahead.
I think it's really important for us to have presence on the medical school admissions committee, and then also to somehow be available to students for retention. So a student can get into your medical school, but are they going to stay? Are they going to thrive? And so I think we need to make sure that the system is designed to make sure that all students can thrive in that environment. But for example, at Hopkins, instead of doing the admissions committee, I joined the college's advisory program. It's basically core faculty in the medical school. So every year I got 5 students who I taught them how to use a stethoscope, which is kind of ironic, and was basically their school mom. And so my first year, I had 5 students. One of those 5 was an African-American woman, and she just matched in dermatology. I think it's just proof of presence, just presence, but also the 10 Black medical students who were in Hopkins class that year. I was their de facto advisor, not by assignment, but they just found me and said, hey, I'm struggling with this. And then I can talk to their advisor and help them. So I think we need to be involved in every step of this process to help to shore up the pipeline.
I'll just say here in Oklahoma, and Dr. Salinas can talk a little bit more about that. For those of us where our underrepresented in medicine groups are lacking, we actually have an HBCU right in our backyard, and that's Langston University. And years past, there had been unsuccessful attempts to keep building a relationship, a very trusting relationship with that university. And so their students go elsewhere. And here in their own state, about an hour and 15 minutes away, is University of Oklahoma. And so how do we, build that bridge and to increase our enrollment just with our own in our backyard? And so Dr. Salinas, talk about that a little bit.
Yes, thanks, Pam. So in my role, that was one of my first goals, was when I started to take a look at where we've been. We really had to take a look at where we've been, where we're at, and where we have to go, and how are we going to get there. And one of the first questions I asked was, where are we with our relationship with Langston University? And the reality was we really did not have a good relationship. There was a challenge in trying to establish a relationship. So we initiated the conversation, and more recently, we are moving towards signing a memorandum of agreement or understanding to build that relationship to help our students at Langston University come to our medical school. I'm working with a number of students from Langston University that I believe will make wonderful physicians. As Pam said, though, unfortunately, they apply elsewhere, they go elsewhere. We're hoping we can change that. We want to be intentional and really build a relationship. So we're excited about our opportunities, but it has to be meaningful. It has to be authentic, and I think it is. And our institution really wants to go forward with this. So we're excited about the opportunity to build this relationship. In addition to that, going back to the comment that was made earlier, we do have a medical school readiness program for which we are working with 141 students in this particular program, where we've identified the social determinants of education, as someone has talked about earlier. And that is, a lot of these students are wonderful students, they're bright students, but many don't have the resources to prepare for this exam, as Chris talked about, known as the MCAT. So we have to do better in preparing our students that are very proximal to applying. But from that 141 students that we're working with, I believe 84 are first generation. 84 first generation students that are very proximal to applying. 44 are self-identified as Black, and we have 8 students from Langston University. So we have to do better, and I think building a relationship is going to really help make a difference.
Excellent. Would anybody else like to share experiences at their own institutions?
Hi, good afternoon, everybody. My name is Ana Maria Viteri, and I'm a first-year medical student at the Medical College of Wisconsin. I'm originally from Ecuador, and I moved here when I was 9. I'm very much interested in dermatology, and something that I've experienced when I share this is I receive the reaction of, oh, do you know how competitive it is? And it's definitely very intimidating and slightly discouraging. So I've kind of moved away from sharing that and just saying like, oh, I'm keeping my options open. Just because I do know that it's so competitive, but, and I'm so grateful for events like this that really kind of it helps me see myself in this field and really see how I can contribute to the field. And I know a lot of other students also shy away from sharing that they want to pursue dermatology because it's so competitive. So I just wanted to share that experience and that perspective from a first-year medical student.
Thank you. Thank you so much for sharing.
We're glad
Mentor is extremely important. So mentorship, and hopefully that you have connected with someone that can help you on that journey. And I think that's going to be another part of the puzzle. Mentorship all the way through, not only in our high school students, our pre-med students, all the way through the different levels of learners. It's important if they don't have a connection that they can relate to. And I think COVID-19 this time has really expanded my ability to have so many mentors through Zoom all across the nation. And so I utilize my Sundays as my mentor day. But I hope that there are other opportunities that arise through time. I wanted to ask you, what is allyship and why is it so important? What does that mean and why is it important?
Well, this morning in my diversity education of from 7 o'clock in the morning till 9 o'clock in the morning, I learned that allyship is you have to include everyone in your circle. And we're talking not only include the medical students, the high school students, be the mentor for the potential residents. We have to include also your patients, because your patients are part of the reason that we're here. And so we have to be allies of a lot of people, but that's the reason we have to use our privileged situation to spread the news and be the example.
I think a great example of allyship is one of the comments Dr. Rosen made earlier, where he said he would look in the medical student pool and he sees a URM student and he'll say, hey, are you interested in dermatology? Let me help you. And if Dr. Rosen helps you, you're going to match, right? That is allyship, to take your position and literally pull somebody along so they can get to where they need to be. So thank you for doing that, Dr. Rosen.
Thank you.
One thing that I've heard a lot from folks that go against what an ally is and how to be an ally is I cannot reasonably include everybody in the conversations when making a decision. And although that's correct, one thing that I would like to point out to folks that are in positions of power is that it's not their job, it's not our job to make sure that everybody's at the table. It's our job to make sure that they have the opportunity to be heard.
Yes, it's like I learned this morning. It's not the opportunity to be at the table. It's the opportunity of being heard and being participant at the table.
That's right. You got to be asked to dance.
Yes.
I think we also sometimes think about allyship in the context that it's not only the role of people of color to push this agenda forward. You know, you don't have to be gay to stand up for the rights of gay people. You don't have to be. You can be white and stand up for the rights of people of color. You know, allyship means it's not just, it's on all of us, right, to move things forward. And if you're not the person experiencing the microaggression, maybe you can empathize and, you know, be on the lookout for ways to help move the needle. So I think it means that we're all in this trying to make things better.
Can I make one more comment along this, the ally? You know, to me, this means that people who are in the in group align themselves with people who are in the out group to facilitate the out group becoming equal to the in group. There is no out group. So I just want to make one more comment about academia and non-academia. So I've said this on more than one occasion. We are blessed. Everybody here is blessed. We're physicians. We're respected. We're given the privilege of caring for people's health. And if you're a dermatologist, you're triply blessed because you've been allowed to pursue a profession that a lot of people can't. And I think it's not just the responsibility of the academia people. Yes, it's sort of a special part of who we are and probably why we are and why we stay there. But I tell the people in the community when I talk to our local derm group, you guys ought to count your blessings. And if you're taking care of, let's say, a high school student, you've taken care of them for warts or for acne or for eczema, and they're talking about going to medical school, you ought to encourage them. You ought to spend a little 5 minutes at the end of your encounter and talk about, you know, here's how you get into medical school. Here are some schools that we know traditionally folks from this community can get into. Can I help you? Talk to their parents. Encourage, if there's a parent with them at a visit, encourage the parent to encourage the child. You can do it. You can aspire and you can achieve. And that can be done in the community level. It may not be the same as giving someone a research project and helping them write a paper, you know, so they get into dermatology. But even before that, at the community level, the dermatologists who are out there in the trenches can see their own patients' potential and encourage them. And they should do that because they're, in the broadest sense, they're in the in group. They've been blessed by being in dermatology. Share the love.
That's right. Another thing I wanted to ask you is, does our workforce match our patient community that you serve? And what are the demographics based on what your workforce is in your clinics and the patients that you serve?
I practice in North Philadelphia, so we have a predominantly Black patient base, and I'm the only, well, no, I'm not the only Black dermatologist. I was for a while, but that's our patient base. The people who work in some of the entry-level positions are also people of color as well. We do have some people of color in our residency program. So I guess it's kind of, we're just a very, very small department. So it's sort of reflective, but not exactly. I think it's a difference between having someone who looks like the patient population, but also having people who are also like culturally competent as well. So I'm from, and my residency program was St. Luke's Roosevelt in New York City. So the home of the first Skin of Color Center, Dr. Perez is one of my professors, the whole nine. So I'm very used to having professors who all look different backgrounds, being culturally competent with cultural humility to take care of all different types of patients. So the second part to that question is, if you do have people who look different or whatever, are they also culturally competent to take care of those patients as well? Because I think that's an even bigger piece as well. Because we know that every person of color in the whole country cannot have a person of color dermatologist, right? So we have to kind of say, okay, well, what are our new parameters? Yes, we know we cannot be everywhere, but how can we make that patient have have a better patient experience? And that would be kind of the key behind that. Does anybody else have want to talk about their demographics in their practice?
The demographics in my practice in Hartford, Connecticut. Hartford is one of the cities where there is the largest population of Puerto Ricans. So I guess that I fit there very uniformly. And I can speak Spanish to my patients without having to use a translator, although legally I have to use the translator because I'm not an official translator. But I can deliver the care to my patients in a way that I understand them and they understand me. But on top of that, I am one of the URMs in the faculty, and there's another one person is an African American. And we just have to kind of unintentionally, we have to kind of serve as the example for the cultural competence, because you have to practice what you preach, otherwise it doesn't work. And by example, you let the others kind of understand the way to approach the patient with a different cultural background.
I actually have the opposite situation. So I am at an HBCU at Howard University. And so the vast majority of my residents and staff are people of color, and so is our patient population. However, recently, due to gentrification, the neighborhood around Howard University has completely changed. And so we now have more Caucasian patients. And I'm just always acutely aware of how I felt on the other side of that equation. And so we are trying to diversify our workforce to match our patient population, which has changed. I recently hired a Caucasian medical assistant who has had all kinds of microaggressions thrown her way. Like, did you know that Howard was a Black institution? Like, people asking her that. Or why did you decide to work here? And so she takes it in really good stride, but I try to be an ally for her. So it's a very interesting paradigm shift from my entire life prior to Howard to now having to diversify in the opposite direction. Interesting.
Very interesting. I have something in the chat, but I don't know if it's really mainly for OU, and I'm not sure how to answer it. I'm not sure if I understand the question. It says, is there a program at OU Medical for students that want to work in the medical field from the 73111 zip code? I'd have to look to see what that zip code is. Dr. Salinas, are you know where that is? I'm not sure what that is.
Yes, that is a zip code. When we take a look at demographic data, we talk about the zip codes sometimes predicting more of your life expectancy than your genetic code. And here in Oklahoma City, that particular zip code, the life expectancy is different than just a few miles away. Mm-hmm. But to answer the question, yes, we actually have a clinic out there, but we are looking to open up our opportunities for high school and college students that want to do shadowing. Right now we had to close down because of the pandemic.
Excellent.
Dr. Allen and the panel.
Yes. Yes.
This is Dr. Clarence Wiley. I've been intently listening to the whole presentation, which has been excellent. And I'd like to say that over the perspective I have starts with me being exposed to Dr. Charles McDonald at Brown University and Dr. A. Paul Kelly, who ended up being chairman at King Drew. So when I started at Brown, I was not interested in medicine, but an experience I had with Dr. Kelly when he diagnosed my tinea versicolor that I had for 8 years as a country boy in Haskell, Oklahoma, impressed me so much that I was motivated to get into dermatology. And Dr. McDonald was kind enough to refer me to WashU, where I trained. And as the first Black resident there, what struck me was that there was a lot of discussion like this about how we can increase the number of Black residents. And I hoped and prayed that it'd be a increase proportional to the population. When I started in the early 80s, and Ted, I've known you for a while, we met, you've probably forgotten who I am, but we've crossed paths a number of times. There were very few Blacks. I heard there were 75 in the whole country. I'm not sure the number is now, but I know it's not exponential. And over the years, what I have done, and it's been mentioned here, it's gotten to the community. From the day when I started my practice here in Oklahoma in 81, I started giving presentations. I talked to whoever would listen, to high schools, sororities, fraternities, first graders, second graders, women of color, Oklahoma naturals, to give a presence to the fact there was Black dermatologists out here. And I applaud, Pamela, what you've done and the position you've obtained at OU, because again, when I started, it was Charles McDonald, there was John Kinney and Harold Minus at Howard. There weren't very many chairmen of departments as well in the country. Unfortunately, what I've seen over the years is that sort of a reverse debauchery situation where there's been, decreasing numbers of minorities in Durham. Like I said earlier, I've never met, and maybe I don't go a lot of meetings now, so I'll slow it down. I've never met a Native American dermatologist, and this is Oklahoma. That doesn't make any sense to me at all. There are too many natives here, such that we should have natives in the program across the country, particularly in Oklahoma. But the problem I'm making is that the presence matters. The question came up earlier: how can non-skin of color dermatologists, get more interaction with the community? Well, how about doing presentations? Like I said, when I first started, it wasn't a week go by while I was presenting to somebody about some aspect of dermatology. And to get confidence, to get trust, I would say, in a non-skin of color dermatologist, there's an opportunity there to go to the Black church, to go to the Black sorority and present. What dermatology is, that you have the understanding and cultural awareness, a sensitivity to care for African-American skin. I can't count the number of times that I heard, and I'm not deriding any one individual. They didn't, touch my skin. I looked from the door. Oh, you have vitiligo. That's okay, just turning white. I've experienced that over my career. And there is definitely a need for sensitization across the board of all dermatologists, but particularly, again, non-skin and color dermatologists. So from my vantage point, at this point in my career, I think getting out into the public, being seen, doing presentations. I know you guys in academia are busy doing academics, but everybody has the opportunity, particularly dermatologists who are just in private practice, get out and just spend some time presenting. First graders understand, can understand about warts and, different types of things. And the more you are seen, I think the more confident the community will be in accepting that you can care for skin of color.
Thank you so much, Dr. Wiley. Dr. Wiley just recently retired, but has been in the Oklahoma City dermatology community for years. So we appreciate his contribution to dermatology.
Thank you.
We just have, we're almost out of time here, but one final aspect of what we can do, and actually Dr. Wiley touched on this. How do we relate and build trust with our patients of color, especially in research, and the role of our churches? How can pastors be an ally with us to reach the community? Anybody like to speak on that? or just in your experience, I'll just say this. COVID-19 has allowed us to put together panel discussions virtually and be able to speak to our people of color through church venues, aired on Facebook Live, and it's an interesting thing to see physicians of color that are put together and then present the facts instead of all of the myths and disinformation about the vaccination to an audience that we look like. And so it was an interesting dialogue. And if we can just change one person's thoughts on the vaccination and the potential health disparities that we already know exist within the people of color of COVID-19, hopefully that will help with just us getting out into the community in that way. Dr. Chris Harris was on that panel with me, and we had several others. Dr. Salinas was involved in that. But it's true that we have to get outside of our community. Many of you may not know who are not from Oklahoma City. Our institution is on the northeast side of our city, which is the historically Black community. And much of the land that we sit upon was taken by eminent domain. And so there's not been a great relationship with just a block away from us. We sit here, but yet at the same time, our relationship is very rocky when it comes to research and getting them into some of our studies. And so, it's going to take us going to them where they are in the community and working with leaders within the community so that they will trust and then come to us. And so I think we're going to have to get outside of our comfort zone and to go into territories that are not usually walked in. And that includes our Native American population, as well as Hispanic communities here as well. Anyone else have any final thoughts upon being a
Dr. Allen,
diversity
yeah, I
champion
think
in many ways? Go ahead.
one of the things that I've had the privilege of doing is leading a few of these community clinics for the vaccination efforts. And everything you hit on is exactly what we've noticed, which is that folks are hesitant to sign up. They feel like that if we are going to them, that we're bringing an inferior set of vaccines instead of the same one. So it is interesting to listen to what the communities are saying and what specifically they are concerned about, because the fears that we consistently hear are often not the ones that we imagined people would have. And so being able to address those more acutely and more directly is going to be key, especially as we fight this pandemic. But beyond, as you mentioned, building trust moving forward so we can continue to serve these communities in an effective way.
Exactly. Anyone else?
Dr. Allen, I was going to say, when we build diversity in our trainees and in our faculty, one of the side effects of that is disruption of stereotypes. And so I think the more diverse the group that we train with and we learn with, the more likely the non-minority physicians who go out into the world will be comfortable and more culturally competent. So I think that's another way to address it.
That's an excellent statement. Anyone else?
I would just like to add that I often like to say that we build trust with our patients in 15-minute increments, right? Most of our patients have chronic diseases, and we build trust over time. And particularly as dermatologists, I like to, remind our residents that we're physicians, right? We care about the overall health and well-being of our patients. Every last patient who comes in my office, no matter how how late I'm running behind, will get the question, have you gotten vaccinated? Do you have any questions? And maybe this visit, the answer is, I don't trust that. And I agree with you. You know, I'm hearing that other patients want to come to the university. They're scared to go get vaccinated at the church because they don't trust what people are bringing to the community, right? But maybe at this visit, they're trepidatious, and I'll talk about it, and I don't make them feel pressure. But when they come back for their 2 or 3 month follow up, you know, maybe things will change because maybe they don't trust the vaccine yet, but they trust me. And so, and we can talk about my experience. And so I try to use those quick visits as ways to address their overall health. And right now that means get you vaccinated.
Excellent. Well, I want to say thank you all so much. This has been a robust conversation, candid conversation, and I think we need to have more of these, but we have to get outside of these Brady Bunch boxes that we're in right now and get boots on the ground. We have to put it in action. I think we've talked a lot about it. We know what needs to happen, and we know that it has to start with us, but must be on every level of our institution for this to be intertwined seamlessly throughout the culture of our institutions. It has to be the norm and not the exception. Thank you all so much. And I will just do final thoughts as we wrap up for the day. So I'm going to once again share my screen. Let's see if I can find it. Okay. I have been taking diligent notes throughout the conference on every presentation. And I may have taken too many notes, so we'll see if I can just hit the highlights. But I just want to give some key takeaway points to leave you with, to remind you of what our speakers discussed today. So Dr. Barbosa and her hair loss update discussed how there are challenges in Black hair. The hair curl pattern, the tightly coiled nature of it can lend many challenges. It breaks easily and grows slower. It's important to ask key grooming questions and get specific. It's important to know that all straight hair doesn't mean it's relaxed. Hair straightening methods, as you know, can be either chemical or heat related. And it's important to become comfortable with the names of common hairstyles. And we know that in African American hair, there's a decreased frequency in hair washing. And due to many aspects, and many times only washing 2 times a month. Sometimes I've had once a month in patients as well, but realizing that and setting expectations accordingly. There's a lot of hair care products over the counter, and it's important to get to know a few brand names, including the Black owned. And we know that the use of protective styles are there to reduce breakage at the ends, but, and I didn't finish that sentence, but we also know that even use of synthetic braiding can also be drying and can also damage hair. So it's important to know that. Use respectful language when asking to talk about patients' hairstyles. Traction alopecia is more prevalent in women and girls, especially those with cornrows. Don't forget the fringe hair sign, and that is the retained short hairs at the hairline. But also remember that patchy alopecia, decreased hair density, may also be a sign of traction from locks. Let's see if I can, there we go. And then the treatment, she went through a great list of treatment for traction, including intralesional triamcinolone, topical minoxidil, there was others, but it's extremely important to avoid those tight hairstyles. And remember that if there is hair loss at the back of the scalp extending to the Parietal regions, think about alopecia areata, the ophiasis pattern, and discussion of treatments including intralesional steroids, JAK inhibitors, oral, more effective, and adjunctive treatments such as minoxidil and PRP. Studies showing alopecia areata is more common in African Americans and Hispanic women. FFA or frontal fibrosing alopecia, just remember to look under the wig. Eyebrows and body hair. And there is no fringe hair sign, but you can have follicular forehead hyperpigmentation, hyperpigmentation of the cheeks and temple region, and a list of medications that can be very helpful, including doxycycline intralesional steroids, finasteride, topical minoxidil. She touched on CCCA, and that studies have shown that there isn't any correlation with hot combs and relaxers use or burns, but may likely be related to cornrows and other hair pieces. It presents with hair loss and breakage, especially at the central scalp area, and associated with burning, stinging, and itching. And remember intralesional corticosteroids, and also the presence of the variant PADI3 enzyme. All right, relaxers and CCCA, is there any evidence that they're associated? No suggestive data. Women in fibroids have shown to use relaxers. Is there any association with breast cancer and relaxers? Not really, you know, that's kind of controversial, but still something to think about. Hair dyes, there's conflicting data regarding association with breast cancer and hair care products. There's an endocrine disrupting and asthma associated chemicals in the hair products, leading to early menarche. Then we went on to Dr. Okoye in the management of PFB and AKN. AKN, chronic scarring folliculitis, especially occipital scalp and posterior neck. Postpubertal young men, less than 40, but can be seen in other ethnicities. Risk factors include metabolic syndrome, obesity, and close traumatic and frequent shaving. It's important to catch it early before large keloidal development. Avoid close shaving, use clippers and increase the guard size, no razors, and do not remove the guard. Several options for treatment: intralesional, retinoids, antibiotics as well, Nd:YAG long pulsed laser, and for those large keloids on the back of the neck, using staged surgical excision. Pseudofolliculitis barbae, growing in a beard, can help. It can be intrafollicular or transfollicular growth. And also, again, avoiding close shaving and not to remove the guard. Remember, a doctor's note for military people but that waiver may inhibit Air Force career advancement. And before shaving, wetting the beard with a moisturizing shaving foam or cream, shaving more often, about every 2 to 3 days, and to shave with the grain, making only one pass, and avoid pulling of the skin. Gentle extraction can be done. A list of topicals in the morning, of antibiotics and retinoids at night. Topical steroids can also be utilized, as well as oral antibiotics as needed. Laser hair removal and other over-the-counter products are helpful. So treating the hyperpigmentation with hydroquinone, there are several other options there, and some through compounding pharmacies in combo can be used with hydroquinone and retinoids. So biases in healthcare, do you really see me? It's important that DEI is an ingredient essential in making the multicultural environment. There are biases in healthcare that negatively impact medical education, patient care, and research. And there is a legacy of mistrust between the research community and people of color. It's important to understand the social determinants of health, addressing the underlying causes of health disparities and resulting health outcomes in different groups of people. Race concordance between patient and physicians has shown to increase minority patient-physician trust. Structural racism is a public health crisis and associated with health disparities, and diversity improves patient care. Then Dr. Heath followed up pediatric dermatosis and skin of color, talking about addressing the importance of hyper and hypopigmentation. And we see tons of acne people, and so in skin of color, addressing the hyperpigmentation is just a regular part of the treatment. We talked about atopic dermatitis variants, and that there's a higher severity of atopic dermatitis and skin of color, increased persistence and hospitalizations. Knowing that eczema herpeticum is most common in Asians compared to Blacks and Native Indians. Staff's scalded skin, recognizing the red skin in an infant is important, looking at the clues from the comparison of the change in color of skin, that purple and plum color. As we move to hair issues, wash day is a real laborious process for African American children. So frequency recommended every 1 to 2 weeks is reasonable. Medication vehicle selection and cultural preferences matter. And how do you examine the ethnic hair? It's important to be respectful and display cultural humility in the way we even ask to examine. And knowing that there is hair discordance between a patient and provider, different hair coil patterns between the patient and the provider, which may lead to lack of understanding of a person of color's issues with their hair, but we all can learn. So avoid the lean in, and invite parents to assist with removal of hair bands, barrettes, and all of these things. Tinea capitis, there are many types. It's important to check the occipital nodes if it's positive. That's highly associated with tinea capitis, and proceed with treatment. Griseal fulvin can be used, but if it's already used by primary care physicians, actually terbinafine is kind of emerging as the more predominant or the first choice to use, and it's a weight-based dosing. Griseal fulvin is 8 to 12 weeks of treatment versus terbinafine 4 to 6 weeks. Oil and grease can camouflage diffuse subderm variant of tinea capitis. And don't forget to check the family members. And you must treat with oral therapy. Topical antifungals, shampoos alone is not going to treat it. Traction alopecia, avoid those tight hairstyles, look for the pustules and the pain symptomatology. Having those difficult conversations, you must complement them with their hairstyle, and then gently correct and suggest other styles that may not be as taxing on the hair strands and follicles. Hashtag save your baby's edges and hashtag save the edges. So let's all use that and get the word out. Natural hairstyles can help save the edges and the hair follicles. Ooh. All right, Dr. Rosen talked about skin lightening being a danger globally. It's a multi-billion-dollar industry globally, affecting many cultures. There's no systematic US study of skin lightening products. It is taking one's natural healthy skin and lightening the tone. And there's many words that help to describe lightening, brightening, whitening, bleaching. They're not all synonymous. We saw that many celebrities are now utilizing this more as a opportunity not to change their race, but to potentially allow it to help them in the industry and increase their status within communities. So historically, light skin was associated with wealth status, not working outside, power and freedom. And so it is, the motivation is to beautify, increase your status and power and wealth and marriage prospects. And it continues to be popular globally. Many over-the-counter brands that can be seen, and some are very harmful, containing mercury and high-potency corticosteroids. U.S. products advertised and sold outside the U.S. That are made for the global market. Rebranding of products have taken place that previously contained mercury and high-potency steroids. It's yet to be determined what they actually contain. Dr. Rosen reviewed melanin synthesis and which products inhibit tyrosinase versus reduction of melanin transfer versus melanocyte toxicity. The best determinant of product toxicity is seen within the ambient environmental conditions. Contact dermatitis can be seen in the mild lighteners. Vitamin C, the esterified form is safer. It is a weak tyrosinase inhibitor, can have some mild contact, but not so much. Hydroquinone, it's banned over the counter in Europe, Japan, UK, and Australia, but still available here in the US. Has some mild skin irritation, irregular pigmentation can happen, as well as exogenous ochronosis. And question mark, carcinogenic, yet to be determined. Mercury containing whitening compounds manufactured outside the US. They're sold illegally through the internet, and they're inexpensive, but they're brought to the US through travelers, immigrants, students, and can develop kidney damage, bacterial fungal infections, mental and neurologic issues, and must be treated with chelators. Glutathione is helpful in legitimate medical treatments, but in skin lightening orally, there's a paucity of scientific evidence. So oral, topical, as well, IV drips have been used, but you can get infections, contaminations with other chemicals, renal failure, hepatic injury, and it's not approved for any cosmetic use anywhere. So just to reiterate some of these things I've already gone through. And so on to Dr. Maritza Perez, aging process across ethnic variations. Elastosis is associated with aging. African Americans have less development of elastosis. Elastosis apparent in Caucasian women as early as age 40 in darker skin tones, especially Hispanic and Chinese in the 60s years of age, but less so in African American females. There's no significant decrease in epidermal thickness of the face and scalp over the decades of life in African American females. Significant decrease in epidermal thickness of the face and scalp in Caucasians, though, in their 50s, and Hispanic and Chinese in their 40s. And UV light leads to cellular senescence. And so the studies that she presented observed similar trends, but also subtle differences in skin changes with age across the 4 studied ethnicities, warranting further investigation. Transcriptomic analysis showed significant changes in epidermal and dermal gene expression across multiple pathways from the earliest age transition studied. And UV exposure strongly affects skin biology and influences changes in gene expression, including gene related to senescence, autophagy, and transcriptional regulation, making a clear case for good sunscreen habits across all ages and ethnicities. Dr. McLaughlin talked about medical students' ability to diagnose common dermatologic conditions and skin of color, and showed that our study, medical students had difficulty in diagnosing certain inflammatory diseases, as well as squamous cell carcinoma in skin of color. And so it's important to reduce disparities in medical school curriculum, including including patients of all skin phototypes in patient viewing experiences, increase diversity of participants in clinical trials, and improve exposure and familiarity of complaints specific to patients with skin of color. And then at the end, diversity champions in healthcare panel discussion. How can we be an effective diversity champion? What does it take? Some of the things that I took away is that there is faculty leadership. Engagement must happen on all levels. Personal and corporate education is important. We must be an ally to our patients, must continue moving the needle on DEI, increase pathway programs, recruit into and also retain faculty in dermatology, recruitment and retention of diverse faculty, and also I should say residents in programs. Allyship is incumbent upon all of us to advocate for DEI. Cultivate cultural competence and humility. Diversity disrupts stereotypes. And mentorship is important on all levels. And we must engage our community. It is the key to building trust with our patients. And so we've had an awesome ride today with our people, experts from all across our nation. And I just want to say thank you to everyone who has stayed with us to the very end. I hope that you have found this program to be educational, enlightening, inspiring, and will inspire you to go on to do greater things within the field of skin of color and in the area of diversity, equity, and inclusion. I just want to leave you with this, that yes, we plan to have our Mark Allen Everett Skin of Color Symposium next year in the spring of 2022, date to be determined, but please be on the lookout for our announcements on that. And it will be determined if we will have a hybrid of in-person and online virtual experience. And so we will continue to keep you updated. And with that, I'm going to give it over to Dr. Stasko, our chair, for acknowledgements and adjournment.
You're on mute.
I think you're on mute if you're trying to talk. Is he there?
Thank you, yes.
Okay.
Probably all for the better that I was on mute. But I think this cartoon pretty much sums up how I feel right now. What a great wealth of information we obtained. I'm not going to belabor this. I do want to thank our speakers. The amount of effort and intellect that went into each of those talks was just incredible. And I would like to thank Dr. Allen for putting all of this together as well. Today's event has just been spectacular. I know that I took away a lot of gems. I know I filled in a lot of practice gaps. And in spite of the fact that I'm a bit tired right now, I'm energized by the things we need to go forward and do. As Dr. Allen said, do save the date. If you enjoyed this symposium and feel like it meant a need, please let us know. Please also suggest additional topics and speakers. And most importantly, tell your friends and colleagues about the Mark Allen Everett Skin of Color Symposium at the Department of Dermatology at the University of Oklahoma. And then join us next spring. And again, if you need any of the information that's in the chat box, remember now is the time to save the file from the chat box. But if you can't remember the addresses, dermatology@ouhsc.edu will get you in touch with us. So again, hope you have a wonderful weekend. See many of you tomorrow at Oklahoma State Durham, and hopefully we'll be together next year in Oklahoma City. Thank you so much.
I will say one more thing. The evaluation is now open and available after you've recorded your attendance. So please fill that out. You will be getting a survey within a short period of time after this symposium, so that we can hear from you on those things that you liked, what things you'd like to see within our next conference, and how we can continue to make it better. So again, with that, I thank you for joining us, and until next time, take care.